Hello, welcome to another pathology video. In this video we'll be talking about celiac disease, which is a permanent dietary disorder caused by an abnormal immunologic response to gluten, a protein that is found in many types of grain. This disease may result in diffuse damage to the proximal part of the small intestine and may ultimately result in malabsorption of nutrients. So the pathogenesis of the disease is fairly straightforward. Essentially, you have the overactivation of gliadin-specific type 1 helper T cells as a result of stimulation by antigen-presenting cells, most commonly with an HLA-DQ2 or HLA-DQ8. And what usually happens is the type 1 helper T cell will activate plasma cells to develop antibodies to gliadin, to endomysial, and also to tissue transglutamase. The type 1 helper T cell will also stimulate cytotoxic T cells as well as other types of lymphocytes to destroy the mucosa. Now, in children, the most common clinical feature is severe malnutrition, which can manifest itself as failure to thrive, abdominal distension, diarrhea, muscle wasting, anorexia, so on and so forth. Now in adults, malnutrition is usually not as severe, and usually patients will present with chronic diarrhea as well as lassitude. Now, in some patients, none of the GI symptoms will be present. They may only present with extra gastrointestinal signs, which may be appreciated in physical examinations. So for example, you may appreciate pallor in a patient who has iron deficiency anemia. You may appreciate bone pain as well as osteomalacia in somebody who has vitamin D deficiency as a result of celiac disease. You may also see that the patient may have a short stature or may have had a delayed puberty as a result of malnutrition, and so on and so forth. There are many other types of extra GI signs that may be associated with celiac disease, but just keep in mind these main ones here. Also note that severe pain is not common at all in celiac disease. It is more common in refractory celiac disease as well as in enteropathy-associated T-cell lymphomas, which we will talk about a bit later. Diagnosis is usually made through positive serologies as well as positive biopsies. There are two types of serology tests that are most commonly used. These are the anti-TTGs as well as the anti-EMAs. Now, these two have very high sensitivities and very high specificities, but the most common serology used is the IgA anti-TTGs because they're cheaper and easier to use than the anti-endomysial antibodies. Now in some cases, you may suspect that there is a false negative because IgA deficiency is indeed associated with celiac disease. So whenever you think that there may have been a false negative, you should always obtain an IgA level, and subsequently you should use the IgG anti-TTG test to determine whether somebody has celiac disease or not. Anti-gliadin antibodies are not used very often because they have a lower sensitivity and a lower specificity. A dual denal biopsy is also essential for diagnosis, and occasionally the patients may have HLA testing. This usually occurs in patients who have a strong family history of celiac disease. As I mentioned earlier, HLA-DQ2 and DQ8 are usually associated with celiac disease. So on biopsy, we would expect to see villus atrophy, which you can see is right here. This here on the left is a normal small intestine or normal duodenum. You can see the villi here. Here you can see obvious atrophy of the villi. You can also see that there has been crypt hyperplasia, which you can see is right here, compared to the tiny crypts which are here. And you can also appreciate a large amount of plasma cells within the lamina propria. Occasionally you may also see intraepithelial lymphocytes, which you can see in this histology slide, are these darkly stained blue dots in the mucosa. Now, treatment for celiac disease is fairly straightforward, but by no means easy. The most effective way is just to have a completely gluten-free diet, although for many this can be hard to achieve. There are several complications in celiac disease, including refractory celiac disease, which is actually very rare. There are two types of refractory celiac disease, type 1 and type 2. Type 2 is associated with a polyclonal T cell expansion, and type 1 is associated with a polyclonal T cell expansion, and type 2 is associated with a monoclonal T cell expansion. It is type 2 refractory celiac disease that is associated with ETL, or enteropathy associated T cell lymphoma, and this is by far the most serious complication of celiac disease. Refractory celiac disease is usually diagnosed when a patient has had over 12 months of celiac symptoms, despite a gluten-free diet. Now, ETL, as we just mentioned, is associated with type 2 or monoclonal T cell expansion refractory celiac disease, and they usually occur in the jejunum or the ileum. Patients with ETL will usually have a history of refractory celiac disease, although this is not always true, as some patients may have had silent celiac disease, which remained silent until the development of ETL. Abdominal pain is also a fairly common sign, and perforations may also occur. Diagnosis is made through endoscopic biopsy, and overall the prognosis of a patient with enteropathy-associated T-cell lymphoma is quite poor, and on average we're talking about a survival of less than 10 months. So this image on the left is actually an image of ulcerative jejunitis, which is associated with celiac disease. But this here on the right, this is actually ETL in the jejunum. So that concludes our session on celiac disease. I hope it's been helpful. If you have any other questions, just leave them in the comment section below, and we'll get back to you as soon as we can. Thank you.